This is just the beginning.
Welcome. I'm Caitlin Owens, a healthcare reporter at Axios and the author of Axios Vitals, our daily healthcare newsletter. I'm joining you from my home in Washington, D.C. And thank you to everyone joining us from Facebook, YouTube, Twitter, LinkedIn, or the Axios homepage. Thank you also to our partner, Philips, for making this event today possible. And today's conversation will be on building resilient hospitals, where we'll be examining how hospitals and health systems have responded to this unprecedented pandemic. Our topics of discussion will include PPE capacity, hospital beds, and an unprecedented pivot to telemedicine. A reminder that today's discussion will be 30 minutes and will be broken into 3 segments. You can follow today's discussion on Twitter at the hashtag Axios Events hashtag or via our Twitter handle at Axios. For the latest news, please follow our dashboard at axios.com. Our first guest today is Allon Bloch, the co-founder and CEO of K-Health, a telemedicine app. Welcome, Allon.
Thank you, Caitlin, for having me.
So you've been on the front lines of some of the most dynamic and quick changes as a result of this pandemic as a telemedicine operator. Can you tell us what your predictions are for how some of these changes will last into the future?
Well, I think it is indeed a very unusual time or once in a several lifetime opportunity to make a lot of changes. You need to bear in mind that we have a healthcare system that's very expensive in the US and the quality is uneven. So it's just a massive opportunity to relook at healthcare and say, okay, how do I want to help people? Do they really need to come in? Can I treat them remotely? Can I do it 24/7? Can I be much more intelligent about what they need and manage people remotely using sensors, using software? How to do it in a way that it changes the current escalating costs. Every time up to now, there's been escalating costs in healthcare, new things were added, it costs more. But the reality is, I think there's just better ways to introduce automation to make it much easier for people to be treated remotely and only bring them in to a specialist or to the ER if they need to, which is much more of a rare event.
Right. And you said something interesting to me when we were chatting about this subject earlier. You said there's a big question around whether it's prime time for using data and medicine. Can you explain what you meant by that?
Yeah, well, the curious thing for me as an outsider to the healthcare industry is that not enough of data is being used for health. I think there's a massive opportunity to give people a much more nuanced approach to medicine, a much more personalized based on information that is their own personal history or from similar situations. And that's sometimes not properly, it's a little bit overlooked in medicine. The ability to give people the way to use AI, use data, and use much more sophisticated modeling remotely is just, I think, is starting to happen. And I think you're going to see more of it.
Yeah, right. And one thing that we have seen that may or may not remain constant going into the future is this, obviously, a surge in demand for telehealth. Can you kind of talk us through what your predictions are for what that'll look like in the near-term future and then longer into the future?
Well, I think to me, it's a basic question. If you look at your pre-COVID life, what do you yearn for? So you probably yearn for a coffee place, a restaurant, a music venue. I doubt people are yearning to, if they're not feeling well, book a doctor's appointment, take days to see the doctor, wait in line, get sneezed on, and then pay a lot of money. If you can resolve your problem remotely in a matter of minutes, which I think most of primary care and chronic care can be done that way, then why not? People are not going to say, well, let me go back and pay much more. I think also there is just this massive opportunity to get primary care to elevate it for everybody, not only for wealthy people in big cities.
Well, that's kind of the question, right? Is does this create more access? If we shift to telemedicine, does this create more access for people that currently don't have access to healthcare? Or does it create new access issues around around internet access and who actually can connect virtually with doctors.
Yeah, I mean, that is certainly something that people need to work on. I don't think we can solve all the problems, but certainly you would need to have a smartphone, and you need to be able to access the internet. But there's a lot of people that are either not insured or underinsured. They have really high deductibles. They can't afford the doctors and the drugs. It takes them too long to be in front of a medical professional. They're not in front of information, because K-Health itself is both an information layer and the ability to be in front of doctors for prescriptions and treatments. So I think we are very much focused on giving people access to really high quality primary care at a much lower cost, which to me is fascinating. There's very few industries that you can improve the quality while lowering the costs.
Right, and that's another argument that proponents of telemedicine make, is that this could reduce healthcare costs. Obviously, there's a lot of bloat in our system today in terms of cost, but the thing is that any dollar that we spend on our healthcare ends up as someone else's profit. And so when we talk about telemedicine and its ability to reduce costs, I'm a little bit skeptical that there won't be at least massive pushback to squeezing these costs out of the system. How do you see that playing out, and why do you think that it would work?
Well, I think the cost of healthcare should go down by more than half. So I think, and I don't look at it necessarily as a cost saving is a dollar off somebody else's profit. I mean, maybe in certain cases if they're inefficient, but I think you can drive efficiency in a way that isn't done today. If a doctor, if the information can be collected by AI, if a system can learn you, if it can be proactive about you, then I think it can significantly lower costs. I think there's also a little bit of a confusion around telemedicine. There's been the traditional telemedicine. It's been after-hour urgent care. It wasn't built for continuity of care for primary care. I think at K, we're building a full-blown health system. We're building the ability to help people deal with a myriad of issues around primary care and chronic care. So I think through those lenses, you're giving people much better access. And I think it's going to reduce costs. But my focus is on my users, on my patients, on giving them that better quality, and in many cases enabling people to get access to healthcare that they just can't afford. So that's the only lens I'm looking at whether we decrease profitability for other people. Some people might need to adapt.
Right. And last substantive question before we get to one fun thing. As someone with a lot of experience in the telehealth, telemedicine area, what have you found that patients like best about using your app?
Well, to me, the most interesting thing is people use K for a lot of small questions. People are really curious about their health. And traditionally, your alternative was, okay, I've got a little rash. Let me wait a few days. Maybe it'll go away. I don't have time. It costs too much to go and see a doctor, too much friction. Right now, they can use an app and get understanding of their information, and based on that, decide if they want to treat it right now or be in front of a doctor. So people use K really often, and for a lot of little things, sometimes big things. And people have a lot of questions around health. People are curious about all these different things.
Now we like to end our interviews with one fun thing. So something that's fun about you, Allon, is that your employees have the option to work remotely during the pandemic. Will you tell us a little bit about where they've chosen to go, and then where you yourself would choose to go if you could?
So we work really well remotely. People work really hard. They care about what we're doing. But we enabled everybody for a year to live anywhere they want in the US. And people have chosen sometimes to relocate for a year to Maine, to Park City, Utah. I personally, if I could, I would go to Jackson Hole, Wyoming for a year. It's fantastic in the winter. It's stunning in the summer. And I sound like a commercial for Jackson Hole, but it's just wild and just unique.
Yeah, it is beautiful. I went there when I was a kid, and I would love to go back when this all ends. So, Allon, thank you so much for joining us.
Thank you, Caitlin.
Next, we have a video from our partner, Philips, and then I'll be back interviewing the CEO and president of Atrium Health, Eugene Woods.
We have been here before. Knocked down, never out. But radical innovation is helping us move forward. We're tearing down walls between doctors and patients, turning homes and veteran centers into virtual exam rooms, improving clinical workflows for soldiers from battlefield to bedside. And just like we always have, we'll come back stronger than ever.
Our next guest is joining us from Charlotte, North Carolina. He's the president and CEO of Atrium Health. Welcome, Eugene Woods.
Good to be with you, Caitlin.
Thanks for joining us. You guys have been on the front lines of the coronavirus pandemic. And one interesting thing that you have done is set up a virtual hospital. Can you tell us a little bit about what that is and what it has looked like?
Sure. Well, providing care and access points as close to somebody's home has been something we've been focused on for a very long time. And as you can imagine, in rural communities that sometimes have to travel for miles to get emergency care, or even in vulnerable inner cities where transportation might be an issue, we've always had this idea of providing access points closer to somebody's home. And we thought, well, what's better than providing some care closer to someone's home than it's actually in somebody's home? And so when we realized the significance of this pandemic and the magnitude of it, we realized that we didn't have enough hospital capacity. So I turned to some of the physician leaders that I have, particularly Tom Batchelor, who was working on this idea of a virtual hospital. And there's nothing like an idea whose time has come. So we said, we're trying to build capacity in the hospital. So what can we do with this sort of new innovation that you've been working on? So we launched the hospital providing care at home, virtual care at home. And we really thought about it in sort of two floors. If the first floor at home was people who had mild symptoms and just needed a little bit of care. And then we had the second floor that had the more severe COVID patients. And so we began monitoring blood pressure, oxygen levels, temperature, all the things you might expect. And then also we would do virtual visits every day with physicians and clinicians and nurses. And then if you needed something in the home, we would actually send somebody to provide you care in person. So we've treated about 13,000 COVID patients in our virtual hospital, and only 3% have had to be transferred or admitted from hospital at home and the virtual hospital into the actual hospital. So it's been remarkably successful for us and our patients.
Wow, that is incredible. Only 3%. Wow.
Yeah.
Go ahead.
I was thinking, for those that might have millennial kids like I do, their whole goal is to never leave their bedroom sometimes. And then I have my mother who's will be 80 next year. And, this concept of aging gracefully at home is something that is important to her. So we think that this virtual hospital concept will outlive this pandemic and be part of how we deliver care differently in the future.
Right. Virtual health does seem to be a huge theme for our future.
Yes.
So this pandemic has been, unfortunately, switching gears here a little bit, characterized by racial disparities. One of the ways this has been manifested is through access to diagnostic testing. Can you talk about the need you saw in Charlotte and how you all addressed those disparities?
Yeah, well, this has had devastating impact on marginalized communities, and it's laid bare the racial disparities that have existed in these communities for decades. You can go back to the Institute of Medicine. Back in 2002, they wrote this seminal paper about disparities in care throughout the country called Unequal Treatment. So we've always been focused on this, and we know that in COVID, the death rate for Blacks and Latinx is about 6 times that of whites. So when we established these relationships in these communities many, many years ago, we were realizing that we were hearing stories from these neighborhoods that they didn't have access to testing. So we essentially geospatially mapped. We used our internal analytic department, and we knew where the prevalence of COVID was showing up in our communities, and we also had this other overlay of where testing was occurring. And right away, back in March, we realized there was disparities in terms of testing. So we have these roving vans, medical vans, and we actually went into those communities. We eventually, and so far, have hit about 55 different community host sites. We're working with influencers, community leaders, and we reduced, actually eliminated the disparities in testing. And so we're still in those communities really working to make sure that we maintain that throughout the pandemic. But the other thing is that I'm really, really proud of, we eliminated some traditional barriers. You don't have to, if you can't afford the test, then you don't have to pay for it. We'll give it to you for free. You don't have to schedule an appointment, obviously, for these mobile vans. And then also, we've taken a holistic approach. We're asking people other questions, not just testing. We're asking them about food insecurity or transportation or legal issues. So if they don't have access to that, we're connecting them with community resources so that we're taking care of the whole person, not just this COVID-related matter.
Right, right. And as you mentioned, it's not just testing, it's case rate and hospitalization rate and the death rate, where we're seeing these racial disparities. What else can we be doing to try to reduce some of these gaps?
Well, I think this is too big of an issue for any particular organization or sector to do by themselves. So, for example, when the Governor Cooper in North Carolina declared mandatory masking over a month ago, we knew that we had to work together, health systems with businesses, with local governments and county governance. So we spearheaded the A Million Mask campaign. And within 48 hours, I had the CEOs of the largest organizations in the country, many of whom have headquarters right here in Charlotte, committed a million masks. That was matched by the county. And we've already, in the past several weeks, given about 500,000 masks to the most vulnerable areas of the community. So we're working with shelters, we're working with construction workers, small businesses. And so to your question, I think this is a model that I think would work throughout the country when you have health systems partnering with businesses, partnering with government to really work together to put this COVID thing underground, if you will.
Right, right. So something also interesting about Atrium Health has locations in a few southern states, but you also have health systems located in urban areas and rural areas. One of the hospitals that you work with is in Macon, Georgia, which is a small rural community, and obviously you're headquartered in Charlotte. Can you talk about the COVID urban-rural divide and how that plays out?
Yeah, well, no matter where you live in this country, you have to take the basics seriously. You have to mask, you have to wash your hands, socially distance. And I think initially the reporting was that most of the COVID was showing up in urban areas where obviously they're more densely populated areas. But if you think about rural America, and people that live in rural America tend to be older, tend to have more chronic conditions, tend to have less access to care. So I think we when we're seeing, because of our system Atrium, we provide care, as you said, in urban and rural areas. We're taking care of everyone. And so in Macon, Georgia, where Navicent is the system that you referred to, and actually Navicent is a tertiary and quaternary care provider. So actually we are receiving patients from other rural communities that are coming to us at Navicent and Macon. And what we're realizing is the value of being a system. You mentioned our headquarters is in Charlotte, and we have this well-developed platform, a nationally leading platform in virtual care. Well, this way, our team in Macon didn't have to create that from scratch. So today, if they need help in the ICU, hours away, we can beam into those ICU units and help the doctors and the nurses and the clinician with a specialized care. Or if we need to observe patients on a particular unit, we actually can beam in clinicians there and talk to patients. It's almost like you're right in the same room. So it shows the value of being part of a large organization with the capabilities that we do have at Atrium, and then also shows how you can work urban and rural care in different ways, but with common platforms.
Mm-hmm. Right, right. And so we're running out of time here, but we like to end things with one fun thing. I have heard that you are an incredible musician. And adding to your coolness factor, you have recorded with some very impressive people. Can you tell us a little bit about that?
Yeah, well, thanks for asking. Actually, I paid the bills in college by playing in bands, so blues band, rock bands, Latin bands, you name it. And part of my philosophy has always been, as people know, is to bring your whole selves to work. So I try to model that. So actually, I'm in the middle of recording an album of my originals at the studio. It's called GAT3 Studios here in Charlotte. It's actually a Grammy award-winning studio that has recorded the likes of DaBaby and rap artists like that and a whole host of others. But I'm actually on my album. Adrian Crutchfield, who played with Prince, played saxophone with Prince, is going to be on it. We have Aaron Sterling, who plays with John Mayer, and Tyrone Jefferson, who ran James Brown Band as a trombone player for like 10 years. So it's just exciting. It's for me, it's actually it's the best form of mental health therapy that I could have. So I'm having fun.
Wow, well, that is incredible. And clearly you are a man of many talents. So we will have to keep a lookout for that album.
Great, Eugene, wonderful. It's great to be with you.
Thank you for joining us. Up next, we have another quick video from our partner, Philips. And then after that, we have one final interview.
What makes a hero? Is it saving lives? What about saving hope? The heroes go out when the world stays in. Search for answers nobody knows. Treat us from a distance. Care for us. Feed us. Keep us safe. Heroes are ordinary people in extraordinary times, who pull us together when life pushes us apart. And when heroes are helping the world, we're here with them. Because together, we make life better.
Joining us now is Dr. Dara Kass. She's an emergency medicine physician and associate professor of emergency medicine at Columbia University Medical Center. She's also a Yahoo News medical correspondent, and she's coming at us from New York City. Thank you for joining us, Dr. Kass.
Thank you for having me.
So you're on the front lines of what is still the biggest hotspot of the pandemic so far in New York City, in the ER. Can you just kind of take us in the room tell us what that was like?
So I think that when you go back to really March, the virus started coming over to America in February that we know of, maybe as early as January, but right around the beginning of March, we started seeing an uptick in cases in New York City that was got us a little bit by surprise. And the way that I described it was kind of like a lot of background noise at the beginning. So I did a lot of telemedicine, and I saw a lot of patients who were at home calling in for fever, shortness of breath, and viral symptoms, while we started seeing some patients start coming into the ER who are very, very sick with difficulty breathing, low oxygen levels, really organ failure, and starting to have to take care of them, not knowing much about the virus. It happened actually very quickly. So the first 2 weeks of March, we started seeing a really high surge of cases coming into the ER and even at home. And we had to very much figure out how to increase our capacity on ICU beds, on telemedicine capacity, and understand this virus that we had never seen before. About that time, I also got the coronavirus myself, and we'll talk a little bit about that, I think, in a bit. But our hospital really had to figure out how to manage an unknown virus that was really pushing our system, while our city also had to figure out how to decrease the transmission of cases. So the weekend of March 15th and 16th, we really started getting ready to lock down New York City, which is a really extraordinary thing to do as the rest of the country locked down. I actually got the virus around then, so I locked down myself in my house, but realized that our hospital was starting to continue to see more and more sick people who needed an ICU bed, and we ran out of ICU beds very quickly, had to take almost every other facility in our hospital that was able to take care of ICU patients, had to turn into a portable ICU or a temporary ICU. Our emergency department areas got turned into temporary ICU as well. And we needed, obviously, the PPE and the ventilators that we were talking about, while also trying to figure out if we could get medications that we thought might be helpful early in the virus. The interesting part about New York City is that we saw the effects of our work of social distancing and starting to mask wear even as early as April take effect pretty dramatically. So that we had a massive surge of cases and an unbearable number of patients die, but we also saw the peak come down almost as quickly as it went up. And we noticed a high peak and then a transition down that really has flattened since March 20th. We've been at since May 20th, we've been in the same place in New York City of decreasing hospitalizations, decreasing positive test rates, increasing capacity to test and trace, and an opportunity to really open up.
Right. And, you guys had the unfortunate circumstance of being kind of the guinea pig for all of this and having to deal with the pandemic as it was coming at you. Now that you have that experience, though, and other parts of the country are starting to, or in the middle of surges, what is your advice to other hospitals and doctors?
So my first advice is actually not to the hospitals, it's to the governors and the leadership of the states and actually the federal leadership, which is to say that we know it works. And what we really need to do is see it implemented consistently and with regulation and with force, not consistent effort to say, if you're not wearing a mask, you can't enter a store. You can't have, bars opening and gyms opening when you have a positive test rate of over 15, 20%. We know that's what works. And unfortunately, it comes down to the healthcare workers on the front lines to deal with the consequences of poor leadership at the federal or state level. And so I have colleagues that actually were, let's say, residents in New York City in March through June who've now moved to Florida or Arizona to be attending physicians in the ER, and they are now bearing the brunt of this again, which is completely unfair because they know what works and they don't have the capacity to implement it.
Wow. And what about at the hospital level? When you talked about converting non-ICU beds into ICU beds and things like that, what are some tips there?
So I think that the interesting part about hospital capacity is that you have to increase your ICU capacity while also making sure you have services for patients in the community as much as possible. So in New York City in the spring, we decreased all hospital visits that were not for COVID. We turned off all, elective surgeries. People stopped getting mammograms for a very short period of time and other preventative care. And we want to make sure that we can keep that open as much as possible while those hospitals are still functional. But you really need to focus on increasing ICU capacity, keeping as many patients out of the hospital as you can unnecessarily, which means increasing your telemedicine capacity, making sure that your anesthesia attendings or anesthesia extenders come into the emergency department to intubate patients, meaning that they are helping with all the critical care. In emergency departments, we saw an overwhelming number of patients stay in the ER and need critical care. And because patients didn't stop coming in and we needed to take care of new patients, the best thing I saw happen in the middle of the pandemic in New York City was this incredible teamwork from everybody in the hospital coming together to take care of the patients where they were. And I would say that that's a leadership culture issue that I would hope would resonate through any hotspot that's happening right now.
Right. And as you mentioned, you did get COVID yourself. Can you just tell us a little bit about what that was like, how you got it or how you think you got it, and then what your symptoms were?
So I don't know how I got it. I think I probably got it at work because I am an emergency medicine doctor, but I also live in New York City, so I could have gotten it community spread. I got it right at the very beginning, so March 15th and 16th, and I started out with muscle fatigue and weakness and shortness of breath, and then I lost my sense of taste. And I was able to get tested earlier, let's say day 3 of symptoms, to know if I had it, and was able to get a result actually pretty quickly because we had started doing in-house testing. I recovered in about a week and a half and was able to go back to work a couple of weeks later. It still sits with me if I have shortness of breath. I wonder, is it part of the virus condition? And we've seen so many people between 20 years old and 60 years old out of that risk of elderly patients who are having long-term consequences of this virus and having to be admitted to the ICU or continue to have symptoms related to shortness of breath or other organ damage. And so we know we're going to learn a lot more about the effects of this virus on what were previously healthy individuals.
Right. And anecdotally, I know you have a family. Did you have to quarantine from your own family?
Yeah. So I actually have it a little more complicated than that, in that one of my children had an organ transplant when he was 2 years old. And so he's immune suppressed. And so I had actually made the decision to move my children out of the house before I started seeing patients in the ER, right when I knew it was going to get bad, but not sure how we were isolating in an individual household, because in China and in Italy, we saw a really high transmission rate amongst families. And we saw that still in New York City amongst intergenerational households. So I moved my children out for a couple of weeks and learned more about the virus. And then finally, I did get it myself. So then I was able to recover at home just with my husband taking care of me. And then we all came back together once I was better.
And something that you and I chatted about offline is just the impact that this is having on women in healthcare, women who work as nurses, as doctors, as home health aides. Can you talk a little bit about that?
Yeah, so I think that I've been doing a lot of work on gender in medicine before this started. I actually started a company for women in medicine, really as a support network. And one of the things that we've seen early on is not just that this disparities in race and, kind of socioeconomic status happens as far as the infection itself, but that there are a lot of other issues like gender inequity that come out when it comes to the workforce, frontline workers, and also taking care of children. Remembering that our child care crisis that's happening that was bad before, or our pay inequity that was happening that was bad before, is exacerbated by this moment. So we're worried about frontline healthcare workers now not even being able to go back to work because of the fact that childcare will be inaccessible or inconsistent, as schools are probably not going to open.
Right. Something to keep an eye on. On a more fun note, we like to end on those with one fun thing. You are a mom, and you told me about a really fun change in your family that's happened throughout this pandemic. Can you tell us about that?
Yeah, so I have 3 kids, one of which is a 12-year-old daughter who has been bored off her you-know-what. And so I decided that we were going to teach her how to cook, although I'm not a very good cook. So what we started doing was ordering these meal kits that, they come to your house and you can make dinner. And so I am now getting home-cooked meals that our family is sitting down for, only I'm not the one cooking them, she is. She has a sense of pride in the ability to make dinner for the whole family, and it gets her off of Netflix for a couple of hours, so that's good. So I recommend it for anyone out there with a preteen child, that they can learn how to cook during this pandemic, if not from you.
Well, there you have it. Some advice for hospitals and some advice for parents. Thank you so much, Dr. Kass.
Thanks so much for having me.
And thank you so much for all of you for joining us for another one of our virtual events today. We hope that it made you smarter, faster. And thank you for our partner, Philips, for making this possible. If you want more content from Axios, whether that be from our newsletters or our podcasts, head over to signup.axios.com. And we'll catch you next time. Stay healthy.